All right, everybody. Sorry. This is the relaxed look, okay? I want you guys to be relaxed, so I'm relaxed, all right? And as you notice, I've grown out my hair a little bit to coincide with the more relaxed look, all right? So this is just the first little bit of that slide. We're gonna be breaking this up into a couple different ones. Some of the ones I've recorded before, some of the ones I haven't recorded until now. So you'll see a couple of wardrobe changes and things like that. Let's get right to it. All right. So here's just the objectives for this one, and this is all second test material. Okay, so we're going to be talking about everything here, which will be on the second and what's actually going to be the last test of the unit as well. So we'll be looking at scoring standardized assessment protocols, which will be part of your group assignment, interpreting those, which we'll be doing as part of lecture and part of the semi case. And then we'll be able to write some professional evaluation reports, although only portions of them. And we'll also be looking at some of this is the more lecture heavy things, which this lecture won't get into, but the next ones will, where we start to look at some of the content, form, and use assessment, trying to keeping that umbrella to guide us and make sure we're thorough and comprehensive. Okay. All right, so there's a couple of goals when you think about like in general assessment. So one of them is just to be as specific as you can regarding the strengths and weaknesses. Now this doesn't mean that you administer 800 tests to an individual. It doesn't mean that you have to find every single area that you could do and empty out your test closet in order to assess the child. What this means is you need to kind of use the information that you have available to you and determine what it is that you can get in the least amount of time. Honestly, like we'll think about that a lot from the school perspective. Like we don't have hours on end to spend with these individuals, but kind of looking at what you can get the most bang for the buck with. And the way in which you do that is by recognizing the interconnectedness of language. So a good example of that is if I have a deficit in morphology, okay, so I'm having difficulty adding and comprehending some of those bound morphemes that are associated with morphology. Okay, we know each one of those changes meaning, which is semantics. So if I assess something that's heavily based upon morphology, I have to realize that that's also going to have an impact on semantics, and vice versa too. If I'm assessing semantics, it definitely has a lot to do with morphology as well. Okay, we also have to think about the overall processes that are leading into this. So we think about much of what we talked about during the cognitive processing section, where we're thinking about the attention, storage, access, all those things, and the interconnectedness of it, which realizes that an upstream effect can have some really, really huge ramifications downstream. Okay. All right, so what we'll be working through today is basically just kind of screenings and case history. These are the things which we do in advance. Case histories we'll get to next. We'll kind of start to focus upon the screening parts. There's three outcomes that will be associated with these, and these are a huge part of the school system because it's kind of mandated by most places of employment. We can do formal or informal. You guys have participated in the formal process, and we've gone out to the schools and we've been administering the PAR or the tower or parts of the CTOP. That's a formal one. When we mean formal, we're usually talking about like a standardized type things. You can also do it as an informal. You can do it as something that's kind of locally developed. And what the problem is with that one is you're losing your evidence-based practice for that one. You're losing your norms. But a lot of places do that because it's been kind of state mandated or things like that. So when that word local there is a little bit misleading. Think about local a lot of time on the district level or even on the state level. Right. Regardless of what you're doing, if we're trying to digest what's a good screening, what's a bad screening, and one of the parts about that one is it needs to have some pretty clear outcomes. Most of them are going to have 3 different outcomes. Okay, pass, fail and refer, or wait and rescreen. Okay, so let's think about some situations in which each of these would be appropriate. Okay, pass, they usually met a criterion. Okay, the PAR is a little bit different than what most of these are going to be because the PAR is standardized, and we go and we take those raw scores and we insert them into the program, and it gives us an actual grade. Okay, which you guys weren't really active in that part of it, but you guys were active in the data collection things. But a lot of these things that schools are doing are going to be some criterion based, meaning if you score more than this amount, then you pass, and if you score less than this amount, then you would do one of these other ones. You would fail and refer. Okay. Now, I do want to realize that you may not only be assessing speech and language. Okay. In a pristine world, it'd be nice. You're only dealing with the things that you're concerned with. But there are some broad-based measures out there that would have you looking at things like gross motor or possibly fine motor or some other developmental type abilities, especially if you're working with the little bitties. So that sometimes can play a role. So sometimes you're making referrals to other people besides just SLPs, but for the most part, you are making referrals to yourself. You're also making referrals to sometimes pediatricians and also classroom teachers as well. Okay, so why would we pass? We reached criteria. Why would we not pass? We didn't reach criteria. Okay, now the more tricky one would be the wait and rescreen. Okay, so what's the situation in which we might wait and rescreen? I'll pause and wait, and you can think at home, or you can hit pause on your computer while you're watching this. All right, but what's the situation where we might wait and rescreen? Okay, there's a number of reasons. One can be behavior. Okay, so you can have a child who's just not going to cooperate. All right, so a story that I tell this time every single semester would be when I worked as a private speech language pathologist going into mostly daycares. We would do an awful lot of screenings whenever we made a new partnership with the daycare, and those who did not pass the screenings, we would recruit for our caseload, that type of thing. And I would go into this new daycare, and I remember exactly where it was, and I remember the little girl's name. Okay, because I disagreed on its appropriateness. Her name was Angel, okay, and as soon as I walked in the building, every single time she would scream her head off. And she did not like me. I never spoke a word to her, never even got within 5 feet of her. Really don't know why, and the daycare directors didn't either. But it got so bad to where I had to sneak in through the kitchen in order to go back to a little nook to where Angel didn't see me because she would spend 5 minutes screaming whenever I walked in the door. Okay, so little Angel would have been a person where we were going to wait and rescreen. And it wasn't going to be me rescreening her either. It was going to be wait and let someone else rescreen her if there was any concerns. Okay, so behavior could be a problem with that. Behavior might not always be a reason to wait and rescreen, okay? So there are such things as challenging kids where that's what you get, okay? If this kid has poor attention, and that's generally how the kid's attention is, then maybe that's what you're kind of getting out of the kid, all right? If he's on medication or if he's not on medication, you just have to consider that one, all right? But I don't want you to think it's an automatic wait and rescreen in that situation. Non-compliance definitely could be. Let's think about one more reason that wait and rescreen was generally used a lot. In the eastern part of North Carolina where I used to work, we had a really high Hispanic population. Okay, so we'd have a lot of kids that would be going to the Head Starts. This is the first time they've been out of a house. And they show up and we do these screenings, sometimes a little bit shy, not really used to whatever. And they would come in and they would have very limited English, and the parents sometimes have very limited English, but our tools were made for English. So in that situation, we try our best, but the child was just having difficulty with this one. In that situation, a lot of times we didn't fail because the process of failing, bringing in an interpreter to do a full comprehensive evaluation for someone who probably just wasn't getting it because of the language barrier was not a good utilization of resources, okay? Like a lot of these places do not have tons of disposable income in order to be hiring out private interpreters to do lots and lots of standardized testing with kids. So you have to kind of pick and choose. It'd be nice if we could sit there and say, whatever, we'll just do the screen, and then whatever, we'll just do it with an interpreter. But once again, resources weren't always available for that. All right, one other thing I do want to say when wait and rescreen would not be appropriate, okay, some things that generally come up as part of a classroom conversation. A lot of people sometimes list, well, maybe if they're borderline, okay, maybe if they're borderline and they were right there close to passing but didn't quite. In that situation, I would say fail and refer, okay, because you have to remember we want to cast a wider net with our screening, not that little narrow net. Okay, if we cast a wider net, the worst case scenario, the next step is that we go and we do a comprehensive evaluation and we find out, okay, they don't need services. Okay, no harm, no foul, that's the cautious approach. Right now, I don't want you casting an extremely wide net because resources are once again limited, your time's limited, things like that. You don't want to be evaluating everybody with a comprehensive evaluation, okay? But you also have to realize that that's better than the alternative of saying, okay, well, they're borderline, let's just pass them, okay? and then we'll sit there and they can go through a school year without getting the services which they need. Okay, so being borderline is not a good reason to wait and rescreen. One last one, and this one has a little bit more to do with psychometric properties than other ones, is being really young. Okay, now I'm not going to say this is a hard and fast rule. You might be able to have some wiggle room, especially with the really young kids. But let's say they just turned 3, so they're 3 years and 5 days old. So we're not scoring them as a 3-year-old. We're not scoring them as a 2-year-old. Okay, so you could sit there and say, all right, well, but if they would have been 5 days younger, they would have gotten this score. Okay, but you have to just realize that argument works the other way too. Like that child who's barely passing as a 2-year-old, despite the fact that they're 2 years, 364 days, they passed. Okay, all right. You have to rely on the norming process of these to understand that there were some old 3-year-olds in this strata. There were some young 3-year-olds in this strata. There were some people from poor environments. There were some people from wealthy environments. Like that's part of the test developer's job is to kind of make sure all that stuff is represented. So as long as the test manual is not telling you to do otherwise, being really, really young on the border for age is not a reason to really adjust the outcome of your screen. Okay. All right, let's think about some good properties of screenings. Okay, they should cover a wide range of language abilities, so that's hard to do. Okay, when you think about something that is a screening, by definition, it needs to be short. Okay, we don't want to sit there and have it ask 45 questions and take forever. The par is actually on the long end of a lot of screenings, being 15 minutes. Now, it's not long. It's a long individually administered one. Okay, so there's lots of things out there that take 20 to 30 minutes to administer, but you can administer as a group, and then the class has lost 30 minutes out of their day, kind of thing. This one's one-on-one, so we're doing it 15 minutes per person, which takes a lot of resources. That's why we're able to do that for the schools, but the schools wouldn't be able to do it for themselves. It's not only that they wouldn't be able to find a budgetary item to address those things, although that definitely has a role as well, is that they don't have the manpower to sit there in one-on-one 15 minutes per kindergartner. It would take quite a long time, in addition to the other things that they're required to do. All right, now, the next one is really the stuff of psychometrics. It's really, really important though, but specificity, this is the proportion, both, all right, so let's get one thing straight first of all. Specificity and sensitivity both are accuracy measures, okay? We're not talking about the negatives. In both of these things, we're saying correctly identify something, all right? With specificity, we're correctly identifying the proportion of negatives, okay? So correctly identifying those who do not have a disorder. That is specificity. Sensitivity is the proportion of accurate identifications of having a disorder, okay? Specificity means, all right, let's back up one step and talk about how this is actually measured. So we do the screening, and it gives us a plus or a minus, right? A pass or a fail. All right. Then the next step would be a comprehensive evaluation. So in that situation, they pass or fail the comprehensive evaluation. So if we have screening pass, okay, and then we do the comprehensive pass, okay, they both passed. Okay, so this is saying that they do not have a disorder, right? That is our measure of specificity. Versus sensitivity is screening fail, and then we go and do the full test and once again fail. All right. Put this in terms that my family is really familiar with, pregnancy test. All right. So the little pee on the stick thing in the morning, that is the screener. Okay. The comprehensive test in this analogy is going to be the blood test that's done at the OB. Right. So wake up in the morning, pee on the stick, positive. Okay, means indicating high likelihood of pregnancy. Go to the doctor's office, says, yes, you are in fact pregnant. Okay, so in that situation, are we talking about specificity or sensitivity? Okay, this one would be sensitivity. All right, we're saying they do have it. All right, they do have the pregnancy. Okay, they caught it. All right, and yes, in fact, they do have it. All right, screen says they have it, and then follow-up test says they have it as well. Okay, so that would be kind of what we're looking at with specificity and sensitivity. These numbers are going to be rather low for language screenings. Okay, part of the reason why the numbers are low for language screenings is because the numbers are pretty variable for comprehensive assessment as well, versus blood test of determining pregnancy is really, really, really high proportion of accuracy. Okay, I don't know what it is, but it's astronomically high. Versus, we're talking about a conglomerate of symptoms with a language disorder. So we're not talking about a blood test where you can just put the little blood meter on you and say, yeah, they have it. Okay, so there's variability within that one, which means there's always going to be some variability within the agreement. But also language is so large and profound and interconnected that it's going to be difficult to have a wide range of language abilities that's going to be sufficient in order to cover all of our areas. Okay, that's just kind of what we're looking at. All right, so this is a little bit of a sliding scale. What we're going to try to really put our weight on is that specificity, though. We want really high measures of specificity, because if this test says they don't have something, then I really want them not to have it. Okay, it's erring on the side of caution if we're a little bit lower on sensitivity, because remember, once again, the next step is just comprehensive evaluation. If I do comprehensive evaluation, I haven't really lost an awful lot, versus the downside would be to not do the evaluation and the child actually needs services but aren't getting them. Okay. And the last one here we already kind of discussed with that kind of clear pass-fail criteria. All right, which I would actually argue you guys haven't seen the results of the PAR all that much. But that's one of its weaknesses. There's not a clear pass-fail for that. It's actually a little bit harder to interpret, but it does. That's why I like it more as an additional measure as opposed to the standalone measure. All right, so that was screenings. Once we've done the screening, we might want to get a case history to go along with it. I will tell you that the case history that we do in the clinic isn't really preparing you for the type of stuff which you're likely to do out in the real world. Okay, because the case history is going to be as much collected from the classroom teacher as it will from the parent. You have meetings that you'll set up with the parent, and you'll have different. If you're moving toward the IEP type things, or if you're doing a 504 plan, those are things that you'll typically have contact with the family. So I don't want you to act like you're just serving people and you're not even informing their parents type thing. But the little speech language case history form that I found we use in our clinic is not all that representative from my experience within the school systems. Okay. One thing I do like for us to kind of to mentalize as we're working through this process is that we have kind of two case history type things. So we have the case history which we're giving the parents, the paper-based thing. We also have one that we're a lot of times more orally administering whenever we're with the parent at the meeting. Okay, or over the phone if it happens to be in that situation. All right. So we have some stuff that kind of makes sense for those. So the one completed before the assessment is typically written, and the one created as part of the assessment is usually the oral case history, which is what that second major bullet point is referring to here. Okay, so we can get some clues in this situation about some different aspects of these. So if we're wondering about motivation, if we're asking things about like perceived severity with the parent, so how bad do you feel this is affecting your child? And they say, oh my gosh, it's just like school is so hard for them. I just know it was hard for me, and I think it's going to be really hard for them. And that's just heartbreaking to me to see them struggle so much. My older child, whenever they do it, it wasn't much of a problem with them. But this one, they're just really struggling. So in that situation, we know that parent's probably motivated. Okay, this is something that maybe the parent initiated as opposed to the classroom teacher, right? Versus the alternative of being like, how severe do you feel like this is, how severely do you feel like this is affecting your child? I mean, his dad and I kind of struggled. We put a lot of stock into being a really good person. He's going to be respectful to you all. He's going to try hard at everything he does, but you know what? I think there's bigger things in the classroom. All right, so parents are going to have that response. Okay. Now, am I going to treat those two individuals any differently if they wind up on my caseload? No, I'm not. But in one situation, I'm going to send home a lot more homework than the other. In one, I know I have an advocate at home that's going to do this one. I'm going to send home homework in both situations, but it does kind of temper our expectations to a degree. All right, it also can tell us a little bit about potential. We can sit there and see kind of what you can see it from a genetic standpoint. So like mom and dad both struggled. This kid very well might struggle as well. Both were poor at reading, still poor at reading, not a whole lot of environment within the home, those types of things. In all these situations, like when we're thinking about motivation, potential, or preferences, once we get down to there, like it's not that we're mailing it in if they have like some response or anything like that. It's not like we're giving them a lower tier of service that we have that one. It's just like you like to know these things because you like to have an interaction with them. Like if you're a robot and you just send something home and it comes back or it doesn't come back, like you need to kind of have that type of nonverbal dialogue to where you kind of understand the things that you can do to best serve this client, because they're all it's the family. Okay, like when you're dealing with kids, you're counting on the family. All right, in some ways you're counting on them heavily. In some ways you're kind of just some little unspoken accountability partnership type thing. But it's a group. So think about that. All right, we're still on that kind of that oral case history, that dynamic one. So I don't spend an awful lot of time on the written one. The next slide looks at that a little bit. With onset, a lot of times I'm asking about this in person much more than I am on that written send home thing, because there's usually not like some set date on which a child has like some type of developmental language disorder. Okay, so they get diagnosed at some point in time if they have one, or if they have been diagnosed at that point in time, but it doesn't mean that like that was the first day in which they had. Okay, so when we have that conversation, a lot of times we can determine, one, was it acquired? So was there some type of accident and things like that? It's usually not. Okay, but then we can understand the developmental aspect of it. So a lot of times you're meeting with third grade, fourth grade parent. Child's been struggling a little bit through on, but then that fourth grade content just became really, really challenging for them. That's kind of corresponding with that reading to learn paradigm shift. And in that situation, you have to sit there and kind of say, all right, well, when do you think Johnny started having difficulty? I mean, his grades just really started going bad this year, so I think fourth grade. Well, what was it like in second grade? Did he do pretty good with his sight words? What was it like in kindergarten? Did he understand what sounds were associated with which letters all that well? What was it like in preschool? Did he go to a pre-K, or did he just go to some person's house and kind of hang out there? Did they read a lot of books? Does he enjoy reading books? Those types of things. Did he see a speech pathologist when they were in preschool? Okay, you wouldn't realize that, like how many parents don't associate seeing a speech language pathologist in preschool with not doing so well in school in fourth grade. They think everything in the middle just kind of happened. Okay, so those are the types of things where I like to have the discussion with them to try to determine it. Situational aspects is really, really important, along with some of the things that can kind of follow on the effects of social well-being. But what I'm more specifically talking about with situational aspects would be the things which we're kind of looking for some of those other kind of social type disorders. So not just autism, but maybe we're having some form of selective mutism, maybe we're having some form of extreme shyness. ADHD could fall in there as well, like how's the child doing? Is it dependent upon time of days, dependent upon mealtime, and things like that. And these are kind of comments that I like to have, as opposed to having an individual write that down. Okay, so one of the reasons why I'm putting most of the stuff in this case and very little of the stuff in the written at home one is because, one, I don't think you a lot of times have a lot of choices of the case history which is sent home, and so a lot of times just your place of employment has a form and you just use that one. But another one is like, I get those things at the doctor's office and it is ready, set, go. Let me see how quick I can fill this thing out. Okay, because like maybe the quicker I get it filled out, the quicker you're going to see me. And I don't like sitting out here in your waiting room, so I'm going to scribble and I'm going to be sarcastic in many ways. Imagine that. And I just like, it gets really, really annoying for all the redundant questions that are asked in there. Okay, so I don't put a ton of this stuff in there. Right, because I don't feel like parents are likely to elaborate like we need to be. And so that's why I like to have the conversation with this one. Now, effects on social well-being is really, really important, because this is kind of showing us how we can recruit the parent to come along board with us. This is showing us how we can recruit the teacher to come along board with us, okay? So as much as some parents may be like gung-ho grades, a lot of parents are much more geared toward kind of, I want my child to be happy type thing, okay? And in that situation, if we find out what it is that they want out of possibly receiving services, then we can gear our services much more toward those types of activities, okay? Which can also reveal to us what the child likes, which is a really, really important thing too. So this one you're probably kind of familiar with. You ask your parents what the kid likes, and you show up on day one of that one, and you bring whatever it is you thought it was, and the kid is just like, I hate that. So I don't want to play with that. Like, can we do something else? So then you're kind of stuck. Right? Makes things a lot more difficult. So it's nice to have a good idea of what the child actually likes and things that you can use in order to try to bring out the best in the child. So this part is the actual written case history part. I told you I only have one slide on it. It's kind of lame here. It's very direct, very specific. Nothing but the facts kind of thing. We're not really, we don't have the opportunity for dynamic follow-up and active listening in this situation. So a lot of times this is just things that they're going to write down. But there's a reason why I have these things in there. Because one, we're usually getting these in advance. Sometimes we're not getting them as part of the one-on-one conversation. And two is like some parents are good at keeping notes of this stuff at home. All right? They don't necessarily have it in their head, but they do have a pretty good idea of it. I don't have it in either place. Okay, with my kids, we didn't do the whole baby book stuff. We made through like 6 months of my oldest, but I think that's about it. We got pictures at the wazoo. But nor do we have like it stuck in my head, because they all blend together to a degree. So I don't remember a lot of times which ones of mine still have tubes, okay? Because at one time I had 5 of them with tubes. And so it's hard to keep up kind of that. If you're at home, then I have resources to where I could look that up and I could actually write it down and have things like that one. Another one is the treatment history. It's really, really helpful to contact previous therapists for a number of reasons. We need to know like what's been tried in the past. This is really, really important so we don't become outrageously redundant. Another really important part about this one that's not really avenue for the classroom, but billing. Okay, you can't be double billing. So if someone else is billing them and you're seeing them, then they can't be billed. There might have to be some conversation on who has the precedence in order to bill, but that's not really the discussion we need to have now. All right, and then family history. And I think a lot of people ask this question just because it's kind of always been asked. Well, do you have any siblings or parents or grandparents who used to have difficulties with speech and or language? Okay, so I tell you there's a good reason to ask this question, but it's not the main reason which you might be thinking of. A lot of people would say, well, I ask it because I want to know if it's genetic or if it's more behavioral. Okay, to which my response would be, okay, do you have therapy kit A for those who are genetic and therapy kit B for those who are environmental? No, so you're going to treat them the same? Yep. You're going to use the same assessment? Yep. Okay, so why might I want to know if someone has some family history of some difficulties? One, yeah, curiosity. Like if you want to say, I'm just kind of curious as to whether or not their prognosis may be fair, excellent, poor, whatever it may be. Yeah, but I think a more important thing to do is to understand who you're dealing with from the parent's standpoint. Okay, like I'm honestly not as concerned whether or not the brother has ADHD. I'm obviously not as concerned if the brother also has dyslexia. Right? What I'm more concerned with is the parent has dyslexia. If the parent has dyslexia and I'm going and telling my kid, all right, go home and do this with your parent tonight. Do me 45 trials of this. All right, my parent might not do it. I might need to follow up with a phone call to the parent in order to explain. If I'm sending home long directions for the parents to follow, then that can be a challenge. Okay, so I do like to know who I'm dealing with from the family. Remember, once again, it's a whole unit. All right, I want to know something about everyone involved in it. All right, let's look at kind of the overall purpose of what we're doing with the case history. It really helps us with kind of guiding the assessment plan. So it's really not uncommon to obtain some piece of information, be it medical or developmental, that completely redirects our entire assessment plan. So we think about, if we're administering 2 or 3 tests, there's usually not all 3 of them of equal weight and importance to us, to where I'm really, really interested in this one, but these are a little bit more peripheral, but it'll just give me a bigger picture. So in that situation, we kind of need to have a game plan for how we want to administer those. So if I know a child has difficulty with maintaining attention, it might be I want to give the first test is the most important one. It might be I want to give the last test the most important one. Okay, it really depends on what I'm trying to do. Like, I have to consider all this stuff, all right? I don't want you to say there's a set in stone rule for this one. But if the child has diagnosed ADHD and they're on their meds, okay, and this is normal for this child, this is what the parents expect of this child, this is the treatment program which has been approved for this child, all right? So they're on meds, and we're concerned that the meds aren't helping with this aspect of attention. Okay, so in that situation, I'm doing my evaluation, and I want to see, as he fatigues, is he struggling a little bit more than he is at the beginning, right? Now, another situation, it's you might want to place that one at the beginning, okay? Because I want to rule out a language disorder and say it's more of an attention-based thing. So I do my language disorder, myself at the beginning, or my told whatever my test is at the beginning that I'm really concerned about. I do that at the beginning, get it out of the way, and then I do these other supplemental things, and I find out I struggle on the supplemental things. I say, well, it might be attention because it's not language. Okay, I'm not saying you want to do either or. There's no right answer to go into those ones, but you do need to consider it, right? It also can certainly tell us if we have like some form of accommodation which may be necessary in that situation. Is there some form of visual impairment, some form of hearing impairment? Are they implanted with cochlear implants? Like, in that situation, we need to check and make sure the batteries are working well. If there's a hearing aid, make sure the batteries are working well. Make sure we brushed up on our Ling's sound test before we're administering anything to that child. Might we need to go borrow some tests from our local clinic? Sometimes they're willing to do that. Sometimes they're not. We do let school therapists borrow our materials at times. All right, also with the treatment, one, it can tell us on what activities they want to do. So we can, once again, work on things to make things enjoyable for the child, although we're not going to have a ton of leeway in that when we're thinking about it from a group perspective. But also we can tailor it toward the actual things that are affecting that the parents are most concerned about, or the teachers are most concerned about. Okay, so a good example would be if you're thinking about improving vocabulary, all right, and the kid's really, really into this type of thing, and so that's something that we can work on, all right? Or we're thinking about improving vocabulary, and we realize that they're about to do a unit on whatever it is in school, okay? So that becomes some of our stimuli, that becomes some of the things which we're focused on and working through, all right? Also with the goals, we can sit there, and if we're recognizing the interconnectedness of language, the way in which we're pulling information from these things in order to try to implement them in a connected manner for the client. Okay? Some things we do need to avoid, and this will show up in your SIMI case practice as well. Clint talked about this in your little discussion. Try to avoid the jargon with the parent in this situation. Like, I'll find they'll often use the jargon with me. Okay, and if they're using it correctly, then okay. If they're using it incorrectly, which frequently they are, due to that whole phonemic awareness, phonics type thing, just all those words that have PHON as their root, which are confusing. So a lot of times I try to avoid those types of things, and I try to explain what it is that they actually, the skill, as opposed to actually naming the skill. Also, like, these things are long. Let's try to avoid redundancy. Let's try to avoid asking them an awful lot of things. And this is the one which I've found kind of the most. I'll scoot to the side to make sure we can see it. But a lot of times our questions kind of ask the individual to diagnose something. So how long has your child had a language disorder? Well, they might not have a language disorder. Okay, like you're doing the case history right now, you haven't even done the assessment, they may not have been diagnosed by anyone before you. So in that situation, you more say, how long have the academic difficulties been present? How long have your child's struggles with school been present? Those types of questions, as opposed to putting a label on it already, okay? So let's try not to label as part of these things. All right, put these two together. These are the two things which you're doing before kind of formal assessment. All right, and at this point in time, we should know, like, why are we assessing this child? And like, what is it what is the complaint? What is the referral? What is it that this child is doing that's giving us reason for concern? Okay, we can find that from the teacher referral, from the parent referral. We can also find that from the screening results as well. What this will also tell us is what we should assess. So what areas are we most concerned on? They didn't pass the vocabulary portion of the screening, all right? We're going to administer the PPBT or the ROWPBT, something like that, right? And then how we should assess. So like I said, lots of things can happen which can drastically affect the manner in which you are administering the assessment tool. So how we should assess. Are we going to give lots of breaks because the kid has ADHD? Are we going to do some before lunch, after lunch? Are we going to do some in small little units? Or are we going to do a whole entire comprehensive test at once? So lots of ways in which you can administer standardized tests without violating the standardization of it, okay? So that's something you do need to keep in mind. All right, the last little bit is going to be on formal assessment. We got just a little bit more before we wrap up this little mini lecture, which will lead right into a previously recorded lecture that we have posted online as well. When we think about this, like, standardized testing is required for eligibility in almost every place that you go. And it's not only your standardized testing. A lot of times it's a conglomerate of different things. So I don't want you to sit there and think it's this simplistic view of, it is in a lot of insurance places, okay? When I was working for insurance, we gave them the PLS or the self, we gave them an RTIC test. That was what North Carolina required, is you had to look at both of them. If they, on any of those things, scored below an 85, we could serve them, okay? Now, with the school-based thing, it's all considered, okay? Like, the child can be struggling in school, get a couple scores that are below the average range, get a couple scores that are above the average range, and then not get served. Okay, the child can have nearly everything above the average range and have one score below the average range and then wind up getting served. Okay, like, all these are pieces of information which are considered by the team who's going to determine eligibility, okay? But something that will get considered as part of that one is standardized testing, okay? It's not the thing, but it's definitely a major thing. As you get out into the field, I don't want you to think that you're going to have access to anything like you have down in our test closet, okay? Like, there are universities definitely just have more impressive test closets than us, and there are universities which definitely have less impressive test closets than us, but there's not too many private practices that are going to have anything that can compare to what we got in there, okay? So tests are outrageously expensive, and you're just not going to have a ton of them. There are a lot of times that maybe have a couple of those that are shared down in a central office, or you're going to have your own copy of a couple different things. Sometimes you're not even the one doing the assessment, which that would be some places, but not the majority. So since you're not going to have a ton of tests at your availability, and since you're not going to have a ton of time at your availability, you have tons of existing information already, which will be really, really helpful. There are webinars which you can take, and there's ASHA kind of practice portal type things that are devoted completely to what's called like artifact analysis, to where the argument can be made that you don't need to do a bit of standardized testing with a school-based child, because you have everything that you need to know right there in front of you. Okay, including the case history and the screenings, but also this child's been doing an awful lot of schoolwork. You can sit there and you can go to that one, see their homework, see their classwork patterns, and you can see what they're doing and what they're not doing. The difference in that situation is you're not getting that normative data. Okay, so I wouldn't fully argue for that artifact analysis in isolation, but I do think it can most certainly be beneficial. So it might seem kind of odd that I'm now defining a screening tool when it seems like we're done talking about screening tools, but there's a reason why I haven't defined it up to this point in time. It's one, because I think we all generally have a decent idea of what a screening tool is, but I do want to kind of illustrate some of the nuances of this definition as well. So an instrument or procedure used to identify a particular trait or constellation of traits at a gross or imprecise level, okay, as opposed to a test of greater precision used for more definitive diagnosis or evaluation. So when we think about our comprehensive evaluations, my argument is going to be that they're actually advanced screening tools as well. Okay, so when we think about what that gives us, it gives us they're having difficulty with receptive semantics, or they're having difficulty with expressive syntax, or they're having difficulty with big, broad areas. That's usually what our composite scores are giving to us. Now, I want to make the argument that we can get a lot more detailed goal writing material by utilizing that comprehensive evaluation as an intermediate screening tool. Okay, so we get their foot in the door, eligibility purposes, with the comprehensive evaluation, and then our work's not done. Okay, our assessment is not done at all. That's what the actual majority of the rest of this lecture is going to talk about, is like your work's not done when you've administered the self file. As long as it takes to administer that thing, it's not done. Your work's not done when you've administered the castle or the told or whatever comprehensive test it may be that you're administering. Okay, use it as an intermediate screening tool to get you, going back to that definition, excuse me, a more definitive diagnosis or evaluation. Okay, so if we perceive our self results as being gross and imprecise, and we perceive our self results as a means by which we can get a more definitive diagnosis or evaluation, I think then we're on the right tracks. Okay, and here's how we do that. All right, so we identify the areas of weakness. That's our composite scores. That's, like I said, receptive syntax, following directions, understanding sequencing concepts, understanding temporal concepts, whatever it may be. All right, and then we start to look for some of those patterns which exist within there. Okay, if we're thinking about, these are specifically from the self, but you can take them from whatever test it is. One little aside, I think the self does a far better job of lending itself to this than do the other test, but that's just my opinion. Okay, so we find out what actual patterns that they're having. All right, we want to look at those error patterns, and what are the error analysis that they're actually demonstrating. Right? If you open up your self manual, you don't have one at home, but if you open it up, you'll sit there and it'll say question 1 was designed to assess this ability, and this ability. So then we say, all right, these are the things that the child was having trouble with. Back when I was practicing, this was something that we did regularly, but I had print-offs of that sheet out of the manual, and I go through and highlight all the ones that they got wrong, and I sit there and say, oh, in this situation, in this area, when we're thinking about their ability to understand sequencing concepts, all right, they missed 5 out of 7 opportunities on that one. That's something they're struggling with. Okay, as opposed to sitting there and saying they missed this one, let's make a go out of it. Well, but they got it right 4 other times. Okay, so do kind of consider that one. All right, after we focused on the error patterns, then we need to kind of look within and also look out. All right, look within, we look at the other areas of language that would be appropriate. Okay, so if we're having difficulty in semantics, we understand that our downstream effect of that one might be having difficulty with expressive morphology. Okay, so we administered something and we said that they have difficulties with receptive vocabulary. Well, it's very, very likely that they're going to have difficulty with the production of sentences. Okay, so that might be something else that we want to do. All right, and there's also where we're expanding to other areas. So we look within. Was it attention? Was it executive function? Was it memory? Was it some type of ability which could have led to these deficits? And then we also say, all right, if I have these deficits, where can they lead? All right, so 4 is saying what could cause these deficits, and 5 is saying what can these deficits cause. All right, 4, what can cause these deficits? 5, what can these deficits cause? All right, so that's it for this lecture. We'll pick back up on the next lecture, on the next slide, and we'll work our way through for the rest of it the next time you see me. will be on a pre-recorded one, and then after that we'll be picking back up with one that is not pre-recorded. So, good day.